Good evening, everybody. My name is Vincent Zata. I am a radiologist, and I want to thank Dr. Alani for putting this together because, uh, like all other cancers, prostate cancer is very important to deal with and to make informed decisions and being on the cutting edge of technology. So my training is, I trained in St. Louis University, just to give a little bit of my background. Went to Washington University for my fellowship. A little bit more statistics. About 1 in 6 men in their lifetimes will be diagnosed with prostate cancer. Some fairly sobering statistics. And out of those 1 in 6 in the United States, about 190,000 men each year have a new diagnosis of cancer. And out of those 190,000, about greater than 25,000 men die of prostate cancer every year. That's, to put it in perspective, that's about 1 man dying every hour from prostate cancer. That's the bad news. Here are some famous people who has been diagnosed with prostate cancer. Warren Buffett announced his diagnosis in April 2012, secondary to a high PSA level. His form of prostate cancer was not the debilitating type, so he did not require surgery, and he was able to go under surveillance, according to what we're talking about today. Robert De Niro, he was diagnosed with prostate cancer in October 2003, but his required surgery. And then Kerry, he was able to catch his cancer very early, and of course, he's still alive today. Unfortunately, remember, one of the highest risks of cancer, developing prostate cancer, is having a first-degree relative, in which Senator John Kerry, his father had prostate cancer and died from that disease. And of course, everybody knows Joe Torre, coming in from St. Louis. He was diagnosed for his prostate cancer in 1999 and was able to win 2 more World Series. Unfortunately, not with the Cardinals. He did it with the New York Yankees, but that's all right. And then Mayor Giuliani, he was diagnosed with cancer in 2005 with a high PSA level. So what do all these people have in common? So they're all still alive, so that's the good news. And as Dr. Alani said, if you're exposed to the cutting edge technology and you're able to catch this early, you could survive a very long and productive life. And in fact, 2.5 million men diagnosed with prostate cancer are now alive today. So that's the good news. And here, as you can see, men stricken with prostate cancer are living longer. The median age of death is rising. And as you can see, compared with new technology and catching this early, men are living up to 78 to 80 years old, with a diagnosis with prostate cancer, as opposed to colon cancer, lung cancer, and breast cancer, which those numbers are rising too, but not as impressive as prostate cancer. So how are we doing this? Well, through research, we're beginning to know our enemy. So how are we figuring out how prostate cancer works? And I'll make this brief, as Dr. Alani already went through many of this. We start with a digital rectal exam to see if you could feel a palpable abnormality. As you notice here, the problem with digital rectal exam is that if the tumor is too small, as you can see up here, the doctor may not be able to feel it. If it is big, then it's more easier to feel. Another test is the PSA, as Dr. Alani already has explained. Then we use a combination of ultrasound and biopsy to try to see if you have cancer or not. But as Dr. Alani has already explained, we talk about this gray zone or this blind area of biopsies. Because of the location, this area denoted as the gray zone, the needle doesn't extend that far during the random sampling biopsies. So any cancers in the anterior lung zone, anterior prostate zone may be missed. So prostate MRI is a new, powerful tool to help fight cancer and to help with management decisions and detection. So the role of prostate MRI is to detect. If you have a high PSA level, do you have cancer, or is it secondary to something else? Okay. And if we do detect the cancer, then we could do a focused biopsy in the area of abnormality instead of doing a random biopsy, in which was already mentioned may miss the anterior cancers, and also we're only sampling about 1% of the prostate. That means 99% of the prostate is not sampled. But here, even though we're only sampling one spot or a couple spots, we're going directly to the site that's suspicious for cancer. Then, of course, people with low risk or low grade or non-aggressive cancer, the type of cancer that does not go outside the prostate or go to the bones, instead of getting repeat biopsies like first biopsy, second biopsy, third year biopsy, fourth year biopsy, because of the risk of infection and bleeding, we could follow and look at your prostate without undergoing the repeated biopsies. That's called active surveillance. The other thing is also, once we diagnose the cancer, MRI helps the surgeon decide how aggressive that cancer is. And if they could spare and help with decrease the complications of urinary incontinence or sexual dysfunction. And MRI helps them avoid some of those dangerous areas. So what is MRI of the prostate? It's a non-invasive test using magnets, very powerful magnets, and radio frequency. Radio frequency is the same type of energy that your radio uses, that you listen to in your car every day. So safe energy. And we use that to characterize your prostate. The picture on your right is an example of a MRI machine, if you haven't seen one before. And the picture on your left is how your prostate looks when we take pictures with that machine. So how do patients usually prepare for this exam? Usually when you get the exam scheduled, you will receive a detailed instructions. But here's just a quick summary. Usually you take nothing by mouth, usually around midnight, except for clear liquids. You could continue your routine medications, so your blood pressure medication, your diabetes medications, your heart medications, you could go ahead and keep taking. Most patients will need a form of bowel cleanse to get rid of the stools, so we could get better pictures and increase our accuracy of the MRI. And also, if you have a fear or anxious of closed places, you could talk to your doctor to prescribe you some sedatives or a temporary anti-anxiety medication to help you calm down and feel sleepy. When you get there, we're going to have you all change into gowns. That is to help protect you because we use very strong magnets. So any metal that you have, whether it's be coins or a pocket knife or anything, will be a danger to yourself and to anyone around you when you step in that machine. The way we solve that is we have everybody change into gowns. We ask you to remove all electronic and metal devices like credit cards, phones. We also have you fill out patient forms like allergies, prior surgeries, and of course, any medical and electronic devices in the body. And we know which ones are MRI compatible or MRI incompatible, okay? But we do that all before you even step into the machine. So once we clear you and make sure it's safe to step into the machine, it's a contrast examination, so we have to insert an IV. We have you lay flat on your back. So if you have like back pain or back problems, you could ask the technologist to make it as comfortable as possible with blankets or pillow or something to help with your back. The technologist will then leave the room. Trust me, you're not going to be by yourself. The room is just immediately right next door, and there's a big window so they could see exactly what you're doing and what you are, and could hear you if you have any questions. And then usually the exam lasts for about 45 minutes at the most, And the good news, as we developed these protocols, about 5-7 years ago, we used to have to stick an endorectal coil into your rectum to get better signal. But because of the improvement of technology, better coils, stronger magnets, better technology, we could spare you this endorectal coil, which is good news. And then also, we've, in the next several months, we have one of the shortest bores in the industry. So a lot of the times we could do, when we image your prostate, your head will be out of the machine, decreasing your coverage, The other one, we could also go feet first. So a lot of the times, not all the time, I can't guarantee it, but your head will be out of the bore and you'll be able to see and won't be covered, okay? And then also, with a bigger bore, you'll have more of a space in front of you, so people who will get anxious and claustrophobic will be a lot less. And then after the exam, usually pretty no restrictions, you could just continue and nothing special needed. However, if you need sedation for anxiety or claustrophobia, then you need to have a driver bring you home. So, any questions at that moment about the actual exam itself? How many of you had an MRI exam before? Yeah. Actually, me too. Just for a test run, when we were testing machines. I've been in there. So I will continue giving an example of how we could use this for detection. 60-year-old man referred by his primary physician to the urologist for an elevated PSA of 5.1, history of urothelial cancer, who had hematuria 4 years ago. The digital rectal exam was negative, and MRI was performed before the first series of biopsy. So you can see that the PSA was just slightly elevated. As you can see from here, there was no cancer detected, and the biopsy course was negative. So in this patient with an elevated PSA, now we could safely say we don't need to do another repeat biopsy for surveillance. We could just do another prostate MRI and make sure nothing develops. Here's another patient who had an elevated PSA for 7 years, fluctuating between 13 and 16, kind of similar to this gentleman over here, motivating 3 biopsy series that returned, they were all negative, 7, 6, and 3 years ago. No functional urinary symptoms, normal digital rectal exam. So before we did another round of biopsies, we did a prostate MRI. And as you can see here, the only abnormality that we could see was this hyper-enhancing area in the prostate. This was normal, this was normal, this was normal. And basically, that type of signal is very consistent with a mild form of prostatitis, just a mild infection, inflammation, not cancer. So in this cases, we were able to just do follow-up and just do active surveillance. One more case here. Another 57-year-old man with an elevated PSA of 4.98 has functional urinary disturbances, normal DRE, and MRI was performed before the first series of biopsies. And in this case, we did see a lesion right here. Little bright, hyper-enhancing area. Little dark area right here. And notice it's in the anterior part of the prostate. So if we did a routine biopsy, this potential cancer may have been missed. But with prostate MRI, we found it. So here's showing these lesions. The higher the score, the radiologist, our job is to score the suspicious lesions. If I give it a 5 out of 5, there's a high likelihood of it being cancer. If I give it a low score, it's most likely normal. And as you can see, all high numbers, 3 and 4, highly suspicious for cancer, okay? And that turned out to be a Gleason 7 prostate adenocarcinoma proven on biopsy. So once we find this, instead of doing a random biopsy, we could go to the area in question. And an area in question is right there in the anterior part of the prostate. And you could see the needle line by this line going straight to the area of interest. And they did, the biopsy was positive. They did a prostatectomy, and the pathologist did see that in the anterior part of the prostate was full of cancer right there. And since we caught it early, patient's follow-up was very good. You could notice for the next 2 years, his PSAs were normal and undetectable with no recurrence of the cancer. So this one, prostate MRI, may have saved this person's life. Here's another example of a high-grade cancer. And here, using prostate MRI ultrasound fusion, we could localize the cancer in multiple planes in an XYZ direction, and we could use triangulation to get that tip of the needle exactly where the cancer is. So we could be almost 100% sure that we were in the right place and getting the right tissue the first time and every time. And this way, the biopsy returned adenocarcinoma, a high grade. And then after prostatectomy, no recurrence of cancer. We caught it early enough and potentially saved another life. And then active surveillance, I got about 2 more points. 72-year-old man, elevated PSA of 10 about 10 years ago. Then a repeat PSA was around 6. So it's going up and down, random. We don't understand it. And his first round of biopsies were negative. However, on digital rectal exam, they did feel something on physical exam on the right side. So MRI, instead of going straight to biopsy, we did a prostate MRI first. And as you can see, we see some normal structures, like the nodules he was talking about, where you get to feel it all the time. And those are just normal regenerative nodules in what we call the transitional zone. So these are classic appearance of non-cancerous nodules. And you could see by giving a low scores of 1 that the likelihood of this cancer is very, very low. And just to make sure, we could, instead of doing random biopsies, we put a biopsy in that specific location. And the biopsies were both all negative. They were all benign, confirming the MRI findings. And due to this, the urologist and your doctor, and of course you, will feel more comfortable with following this with just repeat MRIs rather than repeat biopsies. Okay? And finally, we also use it for staging for curative intent. So here's another patient who had a negative biopsy 1 year ago with an elevated PSA. And as you could see here, despite being in a posterior location, the biopsies did not find this very large cancer. So, but the MRI of the prostate did, and not only did it see it, it showed that it already started invading the seminal vesicles. So it's already outside the prostate, and a more aggressive treatment plan was needed for this patient. So here's a little blurb about a person who received prostate MRI. I had an elevated PSA. The biopsy that year was negative, and the 14 cores that were taken were benign. Over the course of a year, my PSA continued to rise. I saw a urologist and received a second biopsies. I was apprehensive about the shotgun of approach of the traditional biopsy. MRI indicated that something didn't look right. I discussed another biopsy with my urologist, who explained that new technology was available and that under direction of MRI, he could take fewer samples. That sounded good, especially if half the amount of cores would be acquired. I felt comfortable going after an area of concern rather than just poking holes. My diagnosis was cancer after the pathology report. I'm happy I went through the process. I would absolutely recommend this procedure to other men. So we purchased this new technology from Dynacad to make things more accurate, more efficient, and staying on the cutting edge of technology. So when I say a finding, Dr. Alani has to trust me, you know. He has to try make sure that it's not some random radiologist reading his reports. So for him to trust me, he had to make sure I was properly trained. So we took a road trip to the northern border of France to one of the leading experts in prostate MRI and prostate biopsy and MRI ultrasound fusion guided biopsy. We read over 200 cases under his mentorship with surgical correlation, and we saw our accuracy and efficiency improve tremendously. And now, after the end of the program, Dr. Alani was like, "I trust you now." And we took some of the leading experts in prostate MRI to help us build good protocols here locally in this town. I went to one of my old mentors at WashU, Dr. Vincent Zata, and also Dr. Akins, of whom Dr. Alani worked with in New York at Memorial Sloan Kettering. And we developed a rigid protocol to see which patients need prostate MRI, because occasionally you still need the random biopsy, and occasionally you need the prostate, and you need to talk to your urologist to see what is right for you. That is it. Thank you very much.